Good morning, everyone. It's a real honor to speak here. I don't feel worthy, but I'm thankful for the opportunity. I'm going to talk about isolated cranial nerve palsies, and I think the key thing with isolated cranial nerve palsies is figuring out what it's not, that it really is those things and not something worse. So the talk kind of goes beyond just isolated ischemic cranial nerve palsies. I have no financial disclosures. Okay, so objectives, we will go over the eye exam, and I think the key here is if you see a motility problem, also look at the eyelids and look at the pupils. So those three things go together. We're going to understand the presentations and maybe warning signs when it may not be an isolated nerve palsy in order to differentiate between things that might be more serious, the things that you don't want to miss. I thought this was a really cool slide, or a cool chart that was in a recent article published in 2020, and it looked at all the causes of double vision, of binocular double vision that came into UCLA. And the interesting thing is about a third are from what they call sagging eye syndrome, which is something that sort of at least was discovered or became more talked about maybe in the early 2000s, maybe 2008, somewhere around there. And so sagging eye syndrome is where the tendons in the orbit just kind of sag. They aren't quite as good as they used to be, and you can get both horizontal misalignment as well as vertical misalignment from that. You'll see that the next most common cause of double vision in their clinic was a fourth nerve palsy, followed by thyroid eye disease. They then had mechanical strabismus, which means strabismus that occurs after a scleral buckle or a glaucoma drainage device. And then if you have a sixth nerve palsy, which some authors will say sixth nerve palsy is the most common isolated cranial neuropathy. So fourth nerve, sixth nerve. I think in my clinic it has been more often a sixth nerve palsy is more common than a fourth. And then you can see things become less frequent after that. A third nerve palsy is down about 1.9%. So you're going to see that one less frequently. And that one requires a little more special attention because of the risk of an aneurysm, which we'll talk about that a little bit more. Okay, I wanted to talk a little bit more about sagging eye syndrome just because of its prevalence. You might think, oh, well, so if someone's over 90, they may have sagging eye syndrome. Well, it turns out that even under the age of 50, these authors attributed about 5% of the cases of double vision to sagging eye syndrome, and then it increases to about 60% over 90 years of age. So it's certainly more common the older you are, but just because someone is young doesn't mean that they don't have sagging eye syndrome, and I like calling people in their 40s young now. So in patients with sagging eye syndrome, divergence insufficiency, we can also call that age-related esotropia, so where the eyes can't quite get parallel at distance, that was about 35%, and a vertical misalignment was 65%, where I had kind of always thought of the horizontal, the age-related distance esotropia. That was sort of the key presentation of sagging eye syndrome. But in their study, there was a vertical misalignment present more frequently. Okay, now we'll move on to sort of a more general approach to double vision after we've had some time to think about what causes double vision. So most of the key points aren't especially time consuming. I think it's okay, so they often say neuro-ophthalmology considers history so important. It does, but often it hinges on a key few questions. So it's okay to hone in on the questions that are important. So obviously when it started, if it's been there for 10 years, you're a lot less worried than if it just started last week. You want to know if it's monocular or binocular double vision. Is there an obvious cranial nerve pattern? I won't go over that. I know you guys all know what the sixth nerve does, third nerve, what the fourth nerve does. Forced duction testing, if there's a significant ductional deficit. The three-step test, if there's a vertical misalignment. And then remember the emergency. So a third nerve palsy, it can be from a posterior communicating artery aneurysm. I abbreviated that wrong on my slide. It says PCA, which could be posterior cerebral, but you want posterior communicating artery. It could be giant cell arteritis in some cases. It could be an entrapped muscle. It could be from a carotid cavernous fistula, a new skew deviation from a stroke, or if there's multiple nerve palsies, so more than one, or there's also numbness on the face, that should draw your attention. This is not just an isolated ischemic cranial nerve palsy. Okay, so monocular or binocular. This may seem really obvious to some of you, but a lot of people don't check it. I've had referrals to neuro-ophthalmology for monocular diplopia. If it's monocular diplopia in one eye, it is not neuro-ophthalmic. If it's monocular diplopia in both eyes, also very unlikely to be neuro-ophthalmic. There are rare cases where if someone has cerebral monocular diplopia, it's usually polyopia. It may be in both eyes. But what you want to do then is you want to do a good refraction. And if the monocular diplopia goes away in both eyes, again, not neuro-ophthalmic, you can also use pinhole. Pinhole will often, almost always, get rid of monocular diplopia from a refractive error. So again, if they have monocular diplopia in one eye, not neuro-ophthalmic, both eyes, and it resolves with pinhole or even significantly improves with pinhole, then it is not neuro-ophthalmic. All right, so paretic versus restrictive. So force duction testing, so where you can either use forceps or use Q-tips, and you can try to pull or push the eye in the direction that the eye is not moving in. If it's positive for restriction, then the problem is in the orbit. So that's why it's such a great test, is even before you get the MRI, you know where the problem is with force duction testing. One thing about force duction testing, though, is that it's not always as easy to do. If you try to use the Q-tips, which is maybe seen as kinder and gentler, if you push back on the eye as you do it, you'll create slack, and then when you push the eye over, it may move farther. So you have to be a little bit careful with that. Some of my colleagues, they like to check the intraocular pressure in the direction of the restricted gaze. They find that's more reliable. It's something we all do all the time, is check pressure. So you can get an accurate pressure reading, and if it goes up in the direction of the restricted gaze, that's suggestive of a restriction. All right, so this is maybe more of a OCAP or Board's point, but paretic conditions will reduce saccadic speed, so the speed with which the eye moves to a target, whereas restrictive conditions do not. So if you have a restrictive condition, the eye will move just as quickly until it reaches that point where it's tethered, and then it stops. Whereas if there's a palsy, and if it can still move somewhat in that direction, it tends to do so more slowly. And in order to sort of observe the speed of both eyes, it's good if you focus on someone's nasal bridge, so in between their eyes, so you can kind of see what both eyes are doing at the same time. All right, so this is another big thing in neuro-ophthalmology, comitant versus incomitant. Comitant means when you measure the misalignment between the two eyes, it stays about the same in different gaze directions. It doesn't have to be exact, but about the same. Whereas incomitant, it's going to be significantly worse in one direction, better at primary gaze, and then even better when they look away from the area where it's worse. Now, sometimes there can be spread of comitance. We see this the most with fourth nerve palsies, but it can happen in other cases. And a colleague of mine who recently retired, a neuro-ophthalmologist at the University of Virginia, Dr. Steve Newman, said the cerebellum is smarter than herring. So in other words, his point is the brain can compensate, and it doesn't always stay in a perfect fourth nerve palsy pattern on a 3-step test. So what's interesting is both paretic and restrictive conditions can have spread of comitance. And again, incomitant is characteristic of acquired strabismus, so that's where, again, there's going to be a difference in measurement when you look towards the weak side or the restricted side. Okay, I like this slide just to remind people the intracranial course of the cranial nerves. So cranial nerves 3 and 4 both start in the midbrain. Cranial nerve 4 starts in the posterior aspect, and it actually wraps around and innervates the contralateral superior oblique muscle. The 6th nerve nucleus starts at the base of the pons. It then comes up the clivus before going into the cavernous sinus. So keep that in mind if you're ever looking at an MRI. It's good to remember basically those courses. Okay, so ischemic cranial neuropathies, which again, this is what, if it is this, then we're not so worried. They usually get better in time. So an ischemic neuropathy is usually maximal at presentation, meaning it happens and then it's stable. But what's a little bit annoying in medicine, there are all these gray areas, it can worsen for up to 7 to 10 days. So obviously worsening nerve palsy makes you worry more. Is it compressive? Is it inflammatory? Is it something else? But even an ischemic nerve palsy can worsen in the first 7 to 10 days. But by 2 weeks, it should stabilize. So if you haven't already performed a workup before then, at 2 weeks, if it's still worsening, that should be a warning sign. Hey, maybe this is not just a microvascular ischemic nerve palsy. Another annoying thing about ischemic nerve palsies is they can be very painful. This used to stress me out a lot, and maybe it still does, when you have a patient come in, new nerve palsy and terrible pain, and they're 60. Well, you're going to think about giant cell arteritis. You can think about some kind of inflammation in the cavernous sinus. You start to worry about other things. And I think if someone does have severe pain, then you should go ahead, send them to the ER and get urgent imaging. But don't be surprised if the imaging comes back normal and the SED rate and the CRP and platelets are normal. You're like, okay, maybe they just have a painful ischemic nerve palsy. Okay, third cranial nerve palsy. So this, of the three, this is the one that is potentially the most dangerous because an aneurysm, a posterior communicating artery aneurysm, can cause a third nerve palsy. There's something called the rule of the pupil, and unfortunately it's a little bit confusing, and it talks about when is it safe not to look for an aneurysm in a third nerve palsy. Well, the rule is the pupil has to be completely normal, and then the extraocular muscle component of the nerve palsy has to be complete. It has to be the worst. So a little confusing that, well, why is it safe if part of it is the worst? So the eyelid is completely ptotic, the eye cannot look in, up, or down at all, and the pupil is completely normal. In those cases, you could theoretically observe. Now, most experts say, you know what, you hate to be wrong. Was that eyelid really completely ptotic? So they say, hey, if you have a third nerve palsy, go ahead and send to the emergency room urgently for a CT angiogram of the head so that you don't miss an aneurysm. But I like to at least mention the rule of the pupil. So if you've heard of it, or if you're practicing somewhere with limited resources, maybe that becomes more relevant, where you say, hey, look, if this patient meets the rule of the pupil and it's safe not to image, it's just a lot better here that we don't image. So that might be reasonable. Another point is we have people come to the ER with a large pupil, and there's no ptosis, there's no motility defect. So an isolated large pupil, the problem is the experts don't quite say never, but it's almost like practically never a third nerve palsy. But you want to be careful. You want to look, is there ptosis, any ptosis at all? Is there any exotropia or hypertropia, or what they call a reversing hyper and hypo? So if you have a third nerve palsy, if the superior and the inferior rectus are weak, which in a partial nerve palsy, they don't both have to be weak, but when they look up, because the superior rectus is a little bit weak, you'll actually have the right eye be hypertropic, let's say if it was the left eye with third nerve palsy. And then when they look down, because the inferior rectus is now weak, it's now a hyper on the left side because the right eye is able to look down farther because the inferior rectus was now weak on the side of the third nerve palsy. So if there's a subtle third nerve palsy, or you think there could be in the setting of what you thought was a large pupil by itself, well, then you need to image. Then it could be an aneurysm. But if it's really an isolated pupil, it should not be from a posterior communicating artery aneurysm. There's something called aberrant regeneration that we get with a third cranial nerve. So with the third cranial nerve, in that one nerve, you have fibers going to multiple different destinations. And so after there's damage, either from a compressive lesion or trauma, some of those fibers, they get misdirected, and you might have fibers that were supposed to go to the inferior rectus, now going to the superior rectus, or to an eyelid when they were supposed to go to the medial rectus, and we'll talk a little bit about that. Talk a little bit more about that in a moment. All right, so third cranial nerve palsy, we talked about this a little bit already. I think the right thing to do is send them to the emergency room for an urgent CT angiogram of the head, because if it is from an aneurysm, it could rupture at any moment. So all the experts recommend this, and I think for good reason. Now, what's the chance of them really having that happen? Well, it's probably still relatively low, but if there's a chance and you can stop it from happening, then you should. And I would recommend when you send them, specifically say third nerve palsy, look for posterior communicating artery aneurysm on the right side. Because some radiologists, unfortunately, maybe aren't aware, and sometimes they just hear eye problem, so they don't know, like, is it an optic nerve problem? So I would spell out that you're looking for a PCOM aneurysm and on which side. There was actually a publication a little while ago that they collected cases of patients where they had been sent to an imaging center, gotten a CTA, but it was somewhere in smaller communities, and the radiologist had missed the PCOM aneurysm. If you've ever looked at a CT angiogram, it's hard to read. So if you can, if it's feasible, send them to a larger center where they're more likely to have a neuroradiologist or someone who has experience in looking for PCOM aneurysms, because it's hard to find them even for a radiologist. So look for someone who has experience in that. All right, aberrant regeneration. So what is aberrant regeneration? Again, it's a misdirection of the third nerve fibers. And so when somebody looks in, if fibers that were supposed to go to the medial rectus go to the eyelid will look up. And we nickname this a reverse Duane syndrome. So if you remember, Duane syndrome is a disinnervation syndrome where you get co-contraction of medial rectus and lateral rectus when the patient looks in. The globe retracts and the lid fissure narrows, so that's Duane syndrome. Here, with a third nerve palsy, it doesn't have to do with the position of the globe, it's just the misdirection of the fibers. So when they look in, fibers go to the levator and the eyelid elevates. Another one is that the eyelid elevates with infraduction. So again, fibers that go to the inferior rectus are then misdirected to the eyelid. So when the patient looks down, the eyelid raises. So normally when we look down, our eyelids cover our eyes. And so in this case, when they look down, the eyelid elevates. And we nicknamed that one a pseudo-von Graef sign because in thyroid eye disease, because of a tight levator, when patients look down, the eyelid just stays stuck superiorly. You can also have pupillary constriction with adduction because, again, the third nerve carries the pupillary fibers. That one's a little harder to see, but if someone has light irises, then it should be visible. Oh, and again, the key with aberrant regeneration. So who cares? Why do we look for aberrant regeneration? Well, if you have someone come to you who has a chronic third nerve palsy, and they say, oh yeah, they imaged it, nothing's there, they think I'm just in that rare case of a microvascular ischemic third nerve that didn't resolve, and you see aberrant regeneration, then you know there's something, well, unless it was from trauma, which they would remember, but if it's not from trauma, then you know there is a compressive lesion there. So don't believe either the normal imaging or maybe they did not have all the imaging that they needed. And with the third nerve palsy, we talked about how it needed to go urgently for a CT angiogram of the head to rule out an aneurysm, and that's true. But if that comes back normal, again, you could observe for a while and then watch for improvement by 3 months. But you're going to want an MRI as well, because an MRI is going to have the soft tissue resolution you need to look, is there something in the cavernous sinus? Is there something else going on that the CTA missed? So you want to get both. And again, if you have aberrant regeneration, then you really know, hey, there's a compressive lesion somewhere, we need to find it, either getting the CTA, if they have not had that yet, to look for an aneurysm, or the MRI. All right, fourth nerve palsy. So there's the 3-step test, which we'll go over in more detail in a moment. If someone has a bilateral fourth nerve palsy, I think these findings are just interesting. They have a crossed hypertropia. So because it's on both sides, when they look to the left, the right eye will be higher, and when they look to the right, the left eye will be higher. You get X cyclotorsion of greater than 10 degrees. They have a large V-pattern esotropia because, as everyone knows, the tertiary action of the superior oblique muscle is to abduct the eyes. And you get a habitual chin posture that's down so that they can look up away from where they're getting that esotropia. Another interesting one is a congenital fourth nerve palsy. They have a chronic head tilt, so you can look back at old photographs and you should see that their head is tilted in those old photographs. They have facial asymmetry, so facial hypoplasia, contralateral to the palsy, so on the side that's tilted down. And they have large vertical fusion amplitude. So normally people can't fuse more than about 3 prism diopters of vertical misalignment, but they can do significantly more than that. Okay, so 3-step test, probably everyone's favorite test in residency. Which eye is higher in primary gaze? And then is the hypertropia worse ipsilateral or in contralateral gaze? So if you had a right fourth nerve palsy, the right eye will be higher in primary, and the right eye is going to go even higher when it looks to the left, so in contralateral gaze. And then is it worse in ipsa or contralateral head tilt? So a fourth nerve palsy gets worse on ipsilateral head tilt if it's the right eye, and better with contralateral, so that would be to the left. Here's an interesting thing though, there were some studies recently that the 3-step test is only 70% sensitive and 50% specific for a fourth nerve palsy. So there are other things that can give you those same results on a 3-step test. So don't totally say, 3-step test, I know it's a fourth nerve palsy. I think you can say, hey, there's a good chance that it is, but it's hard to know for certain. The other thing, so what are some ways you can add to that specificity? Well, when they look down, because the superior oblique moves the eye down, when they look down, the misalignment should worsen. Again, anytime you're moving in the direction of the paretic muscle, that's where it should worsen. And then also, is the higher eye x-cyclotorted? So you can do that with Maddox rod testing. Also, you can do it once the fundus is dilated. You can look and see, does the fundus look x-cyclotorted? So you can try to add to your specificity. I don't know exactly how much certainty that adds, but I think it's still good to do if you're not sure. Okay, 6, cranial nerve palsy. So again, according to a lot of experts, this is the most commonly affected isolated cranial nerve palsy. Early on, you could have a pattern of divergence insufficiency, so there's some esotropia at distance, but at near, they're still ortho because at near, your eyes are supposed to come in and look together anyway. And again, ischemic mononeuropathy is the most common. There are a lot of causes, really, of all the nerve palsies, but because the 6th nerve has that long vertical course from the base of the pons up to the cavernous sinus, it can be affected by some other things. So raised intracranial pressure common might be too strong, but it's not uncommon that you can get a 6th nerve palsy from raised pressure because the brain and brainstem are kind of forced downwards, and that stretches the 6th nerve as it goes up the clivus. That was the one I wanted to highlight there. There's a few others, but that's probably the main one. Okay. What else is in the differential diagnosis of an abduction deficit? So is an abduction deficit definitely a 6th nerve palsy? Well, no. You could have Duane syndrome, which is congenital, like we talked about earlier. You could have spasm of the near reflex. So this is one where I've actually had patients who have referred to me for bilateral 6th nerve palsies, and they have convergent spasm or spasm of the near reflex. And that, if you're looking for it and aware of it, the pupils are small because that's part of the near reflex is meiosis, and it's usually variable, and it happens when both eyes work together. So if you have the patient close one eye and then see if they can abduct the open eye, usually you'll see that it improves. Also, most people with convergent spasm, they can't keep it up the whole time. Now it depends how long you're in there for, but you'll see variation in the amount of esotropia. Myasthenia gravis, of course, that can mimic any nerve palsy. Myasthenia gravis, though, does not affect the pupil. So if there is clear anisocoria, unless it's from a separate cause, then it should not be myasthenia gravis. Thyroid eye disease, it affects the inferior rectus most frequently, but the medial rectus next. And a tight medial rectus is a restrictive cause. It will stop the eye from abducting fully. You can have other muscle disease, so orbital inflammation or a metastasis to a muscle. Again, medial wall fracture. Okay, so what if a cranial nerve palsy is not improving? So some experts say, if you want to, If one comes into your office, you can image right away. The chance of finding something maybe is around 5%. And for those of you who order MRIs with some frequency, we order MRIs with a lot lower yield than that. So if you want to get an MRI when they first come, I think that's reasonable. But if there's no improvement by 3 months, then you should definitely be pursuing a workup. For myasthenia gravis, acetylcholine antibodies, in purely ocular myasthenia, the antibodies are only positive in about 50% of cases. So a single fiber EMG, you can refer to a neurologist, and that, depending on, it's somewhat examiner dependent, but that's maybe closer to 90% sensitive. So you can think about mechanical causes. Lumbar puncture, you can evaluate for raised intracranial pressure, and meningeal-based disease, meaning look at the spinal fluid. Obviously, if you can refer to a neuro-ophthalmologist, if it isn't getting better, then that's perfectly reasonable too. And saying my time is pretty much up, let me just see, what I might do is just skip to, well, let me show you one thing here. This was an MRI brain of a patient that had a misalignment of the eyes. And I can't remember if this, I don't think this was the case, but I had at a time a radiologist said that the orbits were well visualized on the MRI of the brain. And so this patient, they had this misalignment. The MRI focused that they had these little fluid-filled areas called hygromas, which are what those little measurements are in the top, and the orbits look pretty good. But if you then get an MRI of, well, and there's a partially empty cella just to distract you a little bit, and then you get an MRI of the orbits, and the extraocular muscles are obviously enlarged. So just know if you have an MRI brain, don't settle with an MRI brain if there's persistent double vision that's not improving. You want to get that MRI of the orbits. All right. We'll skip that one. All right, I have a few heuristic points here for the summary. So remember, when there's double vision, you always want to check what the eyelid and the pupil are doing, both the levator function and is the lid fissure changing when the eye looks in different directions, because again, aberrant regeneration of the third nerve. You want to work up all progressive palsies, multiple nerve palsies. If there's sensory loss, which again would be a multiple nerve palsy, that it would involve cranial nerve 5. And if there's lack of improvement, variability suggests myasthenia gravis. And remember, third nerve palsy can be from a posterior communicating artery aneurysm. You want to send them for an urgent CTA to the emergency room, and you may want to pick a larger center that will have a neuroradiologist to read that CTA. Aberrant regeneration in a third nerve means a compressive etiology unless there's a history of trauma, so don't settle for some kind of idiopathic diagnosis if there is aberrant regeneration. If you perform force duction testing and it's positive, the problem is in the orbit. If a motility defect does not improve, make sure you have both MRI brain and orbits. Don't settle for just an MRI brain. If above the age of 50, remember the possibility of giant cell arteritis and look for that when appropriate. And remember, sagging eye syndrome is a common cause of double vision, and in those cases, you won't find anything on testing. But just know that don't be too surprised if you rule out the bad stuff and you don't know what it is. It could be from sagging eye syndrome.
We have a question over here.
Yes, thank you very much. Go ahead.
Snyder, they were talking yesterday on malpractice, and one of the things they've taught me is delay in diagnosis. So what would happen if you have a sixth nerve, you wait 3 months, the patient gets worse and it's some weird thing? Is it better just to go ahead and get an MRI and not have a delay in diagnosis, or can you testify that the delay in diagnosis won't make a difference?
Yeah, that's a good question. So I'm not a legal expert. I tend to be kind of the personality type, not wanting to miss anything. So that's why I think it's reasonable if someone has a nerve palsy, go ahead and order the MRI. I feel as though there's a delay anyway. You have to get pre-authorization from insurance, and then the MRI has to schedule. So it'll be a few weeks. If it significantly improves before then and they want to delay, then that's reasonable. There are times where even with the compressive lesion, you can get fluctuation, some improvement, but most time if it improves, it's better. Obviously, if it were to get worse again, well then, absolutely, then you need to just say, hey, we need to image this.
All right, Mark, thank you.
You're welcome.
What's the youngest age you've ever seen and diagnosed giant cell?
So that is a good question. Probably somebody in their early 60s. Some neuro-ophthalmologists, when I think about them, like at a recent talk, I can't remember now who it was, but the youngest patient they had seen in their 35-year career was 57. So I think the over 50 recommendation is to be safe that you don't miss someone. But yeah, there are, I think the Will's Eye manual might even say in the case of double vision, if they're over 55 and have double vision, think about GCA. So you can take that into account. If they're in their 50s, less likely, but you know, I think certainly less than 55 becomes even less likely. Over 55, you're starting to get into the realm where, yeah, there are people who see it. And of course, there are case reports out there of people who are 48 with it. You know, I think those are somewhat questionable. I mean, almost always if someone's less than 50, we don't think about GCA, which internal medicine doctors or people in other fields will come to us with patients in their 40s saying, hey, we need a biopsy. And we're like, hey, look, you know, it's so low, we really don't think that that's indicated. Good question. Yes?
So I'm an anterior segment person, so I see a bunch of zoster. Oh, thank you. And I've happened to see a few people that, I mean, they clearly had the V1 rash, everything, it was zoster, maybe even a little uveitic involvement. And then as their pupil swelling starts going away, I realize that they have a cranial nerve palsy. Would you image that, or you, from what I could tell in the literature, it's pretty uncommon, but not a zero kind of, I mean, happens.
Yeah.
Would you image that, or say, obviously this came from zoster?
Well, I would still image it, even though I think it's probably from the zoster, yeah. Again, I order so many MRIs now that if someone has a nerve palsy, I think it's reasonable to order. Now, if you wanted to say, well, hey, let's wait 6 weeks and see if it improves because you had a reason, again, you're within your realm to do that for any isolated cranial nerve palsy. But again, if it's persisting or not improving by 3 months, then I definitely would.
Are you saying to do a CTA on any third nerve palsy?
Any and every third nerve palsy, unless, now, they've had it for 10 years, okay. But yeah, any new third nerve palsy, I think you can send them to the ER for a CTA of the head urgently. Again, if you want to follow the rule of the pupil and you're really confident with your exam, you can make an argument for that, but most experts say, gosh, but you hate to miss it. So.